Quick announcements. Dr. Schul has the QI code for all the fellows to log on. Make sure you take a picture of that and send it off to Stephanie. As you guys all know, we are now getting CME credit for these meetings, for these lectures. So after the lectures, after this one, you can certainly log on, answer a few questions, and get an hour of CME credit for this as well. Just to introduce our speaker this morning, for those of you who do not know, I'm sure everybody knows Marlin, but for those of you who are not familiar with him, he's a graduate of the Indiana University. He is a fellow specialist in emergency medicine, just like many of us. He is the immediate past president of the AVLS. He's been involved in numerous published peer-reviewed publications. Has been given numerous awards in the field of venous and lymphatic medicine. He's got 3 grown daughters that he enjoys spending time with. Marlin is somebody that, if you aren't aware of, basically has an immense knowledge of venous disease. And I know I call him up for advice all the time, and I know some of you already do that, but this morning he's going to speak a little bit about the management of the anterior accessory GSV and a bit more detail in terms of the disease and pathology and how to take care of these for our patients. So without any further ado, Marlin, you want to take over?
Well, thanks for that kind introduction, Ken. It's an honor to be here this morning, and thank you everyone for attending. Let's get rolling. So the title, Management of Anterior Accessory Great Saphenous Vein Reflux. This has actually been a focus of interest of mine for many years as payers stopped covering this about 12 years ago. And that led to a lot of effort by a number of different individuals that ultimately helped change policy. So the goal today is basically to provide some background, some challenges, to look at some of the more relevant pieces of literature that have come out in the recent years, and then right into how do we manage some of these vessels that can certainly be challenges from time to time. I want to thank my ultrasound team. These ladies work so well together. The change in protocol this year, where the focus on the anterior accessory being documented, is a very important one, and these ladies are all over that. I wanted to give them credit because they're responsible for a lot of the images that we have today. So background, historically, the anterior accessory was considered a tributary of the great saphenous vein, and that's where a lot of the controversy has come from. You've got people making policies that only practiced when surgical stripping was done. This was not the goal of surgical stripping. If you opened the groin and you did a flush ligation, you also addressed many of the named branches, or you would just leave them alone. But it was felt that the anterior accessory was nothing more than a tributary, and that treatment of this should be done with phlebectomy or chemical ablation if treatment at all. There's a move afoot with the UIP and the AVLS, the AVF, in working to change this nomenclature. Currently in the nomenclature of the UIP, which is somewhat the standard for naming vessels, the AAGSV is titled the AASV, and that changed after the prior version where it was appropriately named. But as we know, this vessel sits in the same tissue plane as the great saphenous. We know that it sits right over the femoral vein. Here you can see a big dilated anterior accessory lying just anterior to the femoral vein. And I think it's important to look at other structures that you have to be concerned with. And if you look at the groin, there's a lot of structures there. And when it comes to the nerve structures, one thing that I found was when you start looking at your incidence of paresthesias, I had more patients that had paresthesias after anterior accessory saphenous ablation with laser or radio frequency than any other vein that I treated. I mean, I think that everybody knows about the sural nerve, everybody knows about the saphenous nerve and the potential risk. We also know, however, that these sensory deficits all improve usually within 3 to 6 months. But you won't be surprised to find that when you treat the anterior accessory, some patients will have some unusual sensations, and I believe that's just all because of the inflammation at the time of treatment, and we'll talk a little bit more about that. This is a common problem, and as I mentioned, it has fallen under scrutiny, but we're fortunately in better times. But I'm going to quickly review some of the more recent literature. This was the first study that I actually saw that looked at naming this vessel the anterior accessory great saphenous vein and looking at treatment for the isolated pattern of SFJ reflux from the junction to the anterior accessory. These patients in this study, the incidence was 6.9%. You can see they didn't have terribly severe disease, most C2, C3. There were no ulcer patients. The results basically showed at 12 months that they were able to preserve the saphenofemoral junction and that the normal great saphenous vein remained normal after EVLT ablation of the anterior accessory. This was a single center study that we did. All of our payers stopped covering anterior accessory saphenous veins, and we looked at consecutive patients, 241 consecutive patients. 23 of those had this pattern, or 13.6%, 145 with GSV from the SFJ. And what we wanted to do was compare these patterns to controls. I used some statistical wizards, if you will, from the Purdue Statistics Department. They did some log linear modeling and found that the great saphenous and anterior accessory have statistically the same pattern of severity and signs and explanatory values. In other words, they behave the same. The other thing that they showed was that the anterior accessory was found significantly higher in female subjects, and that was when you took away the I won't say bias, but they were able to distinguish that female subjects had this pattern more commonly. In a registry trial, we tried to do the same thing, looking at a larger number of patients, looking at demographics, duplex findings, revised clinical severity score. And what this study did was actually separate these groups into primary versus progressive. If you look at the literature, it's clear that that the anterior accessory is a common cause of recurrence. I will argue progression of disease. One of the reasons that we used progressive group in this paper was to help bring the chronicity of venous disease forward as we look at managing these patients. The critical findings here were basically, when you looked at the primary group, they did have an RV revised clinical severity score that was a point higher. That was statistically significant. And that makes sense given the fact that if somebody has had a prior treatment, it should have provided some benefit at the end of the day. When you look at the seat distributions, I think when you look at the primary versus progressive group, this puts a different face on these patients. There are ulcers in both the primary and the progressive groups, which is not unexpected. But when you look at the lower graph and you look at the incidence of ulcers between the anterior accessory patients and those with GSV reflux, these actually are very similar. And I think that's important to note because we don't typically think of anterior accessory patients as those that develop skin lesions, et cetera. When you look down at the individual groups in the primary group, the great saphenous had a near 1.5 point worse VCSS with the great saphenous versus the anterior accessory. But when you looked at the anterior accessory saphenous in the primary groups, they had an incidence of superficial thrombosis that was nearly 3 times higher than that of the great saphenous. Now, when we think of these, and when you look clinically, if you've seen a lot of limbs, I don't think this came across as a surprise, but this was the first time this was reported. And when you look at the progressive group, there was no meaningful difference between the groups in their demographics or VCSS, except for the presence of superficial venous thrombosis that occurred in 12.9% versus 2.7% in the great saphenous. So in these studies, we identified these have the same disease severity when compared head to head. Variation maybe in the clinical severity score, but the incidence of superficial thrombosis kind of put a different taste to this vessel as we were continuing to try to build the literature to support patients here. when you look at the CVR paper, large number of patients, this was not an incidence study, but they looked at 103 limbs with isolated anterior accessory GSVs versus 10,000 plus with isolated GSVs. They found no pre-intervention differences between the groups. This is consistent. Basically, if they present with anterior accessory saphenous or great saphenous reflux, the pre-intervention evaluations were very, very similar. And they found that if you add AP to ablation for anterior accessory GSV subjects, that demonstrated improved quality of life compared to, or improved outcomes, I'm sorry, compared to ablation alone. Again, a large paper supporting the literature that we have been putting forth to date. And lastly, you really want guidelines to support this. You want clear references that say, well, if you're treating a vessel, that you've got the science behind it that can actually support what you're doing. And the 2020 appropriate use criteria, it's not a guideline, but it does serve as a reference for different treatments. And when you look at this, if somebody's got a symptomatic patient with varicose veins, skin changes, subcutaneous changes, healed or active ulcers, it was determined by the panel, all the authors that you see there, to be appropriate. And ablation of the anterior accessory in a symptomatic patient with edema due to venous disease may be appropriate. The others really come down, do they have reflux or not? And if they don't have reflux, I think we could all agree we probably don't have to treat that vessel. But I think now we've got support in the literature that the vessel is a meaningful vessel. We know that it causes a significant amount of symptomatology and morbidity, and we've got literature that supports treatment of this vessel when it's a problem. So let's talk about management. And I think when it comes to management, I separated this basically in the diameter of the vessel and the length of the vessel, because these vessels they can be challenging based upon how they present. So if we look at just comparing these, the large vessels, I just arbitrarily said 5 millimeters. We could argue that that's not a big vessel, but just for the sake of argument, 5, and small vessels less than 4. I will say that if you've got a vessel, an anterior accessory that's less than 4, I think you can basically use any treatment and close that vessel. Just make sure if you're sclerosing it that you use a appropriate concentration to get a good injury to that vessel wall. But smaller vessels, we all know, whether it's laser radiofrequency, glue, Varithena, or ultrasound guided foam, we're going to get a response in that vessel. At least we should, with rare exceptions. For larger vessels, though, there can be many nuances, and I want to present a case to kind of walk through a principle that we apply when we do all thermal ablations. But this is a patient that, well, I'm sorry, I got ahead of myself. I talked about all these things, so I'm going to move right through this, right to the case. So this is a 49-year-old female, phlebolipedema, and a patient with a BMI greater than 50. Aching and pain were dominant symptoms. She did have swelling. She had a prior GSV ablation in 2016 and was successful. However, her current pattern is a persistent anterior accessory with failed laser and Varithena in 2019. Staff say she's a problem child because she doesn't respond to any treatment that had been provided to date. Her carrier is now United Healthcare, and the question is, what treatment would you provide? Anybody have a guess? United Healthcare doesn't cover VenaSeal, right? So would you do laser again? Would you do Varithena? Would you do radiofrequency? I chose to do radiofrequency. So this patient, this segment was 12 centimeters long. It was obviously big. It was easy to access. We treated her using 5 cycles of RF, 2 centimeters from the junction, then the next segment 4 cycles, the next segment 4 cycles, next segment 4 cycles. I look for feedback from the RF device in the last 5 seconds of the 20-second cycle. I want to see that those in a 3 centimeter catheter, I want to see that wattage is consistently below 6.5, and I'm going to share why we do that. But I told this patient before she got off the table that this vessel would likely not close. And it's all because I didn't get the feedback from the RF device. Now, keep in mind, this is the same principle I use for any vessel that I'm doing RF on. I use the same look at that 20-second cycle in the last 5 seconds. And I believe that that last 5 seconds will tell you whether you've got a full thickness injury. But instead of that, look at the Shadikoff study, where they looked at the morphology of vessels that were treated with radiofrequency ablation. They showed that 1 and 2 cycles fail to injure all 3 layers of the vein wall, whereas the 3 cycle approach, meaning you're sitting at that segment, whether it's a 7 centimeter or 3 centimeter segment, and you're hitting that button and you're delivering a 20-second cycle of heat. And they felt that the 3 cycle approach was preferred. Now, when you look, where am I getting the idea that I need to give more cycles and see that wattage down? This was an abstract that I saw in Anaheim many years ago. And this was a Chinese abstract. It may be printed in Chinese literature, but I can't find it. But what they showed was when they had the wattage less than 14 for the last 5 seconds of a 7 centimeter catheter, or less than 6.5 on a 3 centimeter catheter, they had better closure rates compared to any other parameter. And what I'm referring to with this is a patient that we treated yesterday. This is the first cycle of a large great saphenous vein near the junction. And in the last 3 seconds, that number to the right, that 21, that's not, this is a 7 centimeter catheter too. That 21 isn't even close to 13. And so we know we're going to give another cycle. Well, with RF, we do give another cycle, generally close to the top. And so the 4th cycle that we delivered, however, was consistently below 14. And it's not uncommon to see numbers in the single digits. But I feel very comfortable now that that top segment is closed after applying that approach with radio frequency. And the problem that we had with that anterior accessory in this morbidly obese patient was that we were not able, well, given 5 cycles in a segment's quite a few. I typically don't give that many. I commonly will give 3. I sometimes will give 4. But I gave her as much energy as I thought I could. She never felt any discomfort. But I think this is a useful tool as you're doing radio frequency to try to make sure that you're getting a full thickness injury. I believe the Shadikoff trial is certainly supportive, and you know, I've been happy by applying this principle over the years since seeing that abstract at a conference. So if we look at laser for this, I think it's a similar issue. If you go back to when you first started treating veins and you're doing endovenous laser, well, how much energy were you going to give? Okay. Are you going to treat a 4 millimeter vein the same way that you treat a 10 millimeter vein? I think when you look at that and you look at this article by Thomas Probstl, you will find that you have to look at it a little bit different. There have been 3 different authors. Probstl looked at all these patients and he looked at the great saphenous vein as a cylinder with a surface area. And the median fluence, which is joules per centimeter squared, approximated 12 joules per centimeter squared. It's not hard to do an approximation of the energy that you want to deliver if you take a measurement in the proximal thigh. Well, take 3 measurements. You take measurements at the distal segment, the mid segment, and the proximal thigh. You can make an approximation of surface area and know how much energy you want to deliver. If you look at Rob Min's look at laser, one of the founders, one of the first users of endovenous laser, he recommended getting half of the energy that you wanted to give in the first third of your ablation of a great saphenous vein, and then give the last half just over the distal 2/3. So when you're using laser, you want to tailor this different. I don't do a calculation when I'm doing laser. I use it for short segments. But what I can tell you is I'll just basically sit on that and do a slow pull as we're managing these short segments with laser. So let's look at short vessels. And I think we can recognize, if you're using a 7-centimeter RF catheter, that could be a challenge here. If you can get into the vessel and you can pass the wire, you can certainly pass the sheath, but you may be longer on your sheath than the vessel is long. But you have to consider these things, because some of these things you're not going to be able to get a catheter in there so easy. So thermal, we've got radio frequency or laser. I would apply the same principles, but short segments, it's just not going to be as long of a procedure, and you have to recognize that there may be a challenge in accessing this vessel with a catheter. Non-thermal, I think this is something that would be helpful to have a video. Kathy Gibson's done some work in basically passing a Cook needle into perforators and into other segments to use adhesive for these patients. When you're done with a glue case, you've got plenty of glue left over. You've got Cook needles in your practice. I've done this less than a handful of times for patients that I felt this was a more appropriate treatment before we did the rest of the care. But bottom line, you might want to consider glue in this instance, and it might be a direct puncture. And I'd like to get a video to share. I just didn't have one for this, but I want you to think about that. MoCA, I think, would be impossible for these segments. I know MoCA can deliver results. I personally find it, I almost need 3 hands if I'm going to do MoCA, and I'm sure some of you on here love MoCA and have great results with it, but it's not something that you would typically use for a small segment like this. Varithena, absolutely possible, and ultrasound guided foam, all able to treat these small segments. And obviously, if you're going to a sclerosed approach, you're going to get a lot more than just this vein treated in a given session. So tips and tricks. I think that smaller anterior accessory saphenous vein access, if you hold the probe yourself and you want to pin that vessel in place, because a lot of these vessels will try to move on you. Yes, they're in the same tissue plane, but they're not tethered necessarily to the same degree that the great saphenous is. And sometimes if you have a little traction on the skin, it will fix that vessel in place so that you can direct that needle right into the vessel without it moving. I think a counter to this, if you're doing a pin stripping and you're holding counter traction, pushing toward the groin as you're pulling that vessel through the saphenous sheath, the difference here is you've got somebody else pulling as you're pushing the needle the opposite direction. But it's a principle, I think, that can help for access for some of these smaller vessels. Make sure, we talked about the anterior cutaneous nerve. I make a extra effort of putting sufficient, well, it's not just sufficient, but extra tumescence underneath the anterior accessory veins that I'm cauterizing. I let patients know that they may have some sensory changes, but they'll be temporary, all because you can't necessarily see that cutaneous branch, and you're not going to be able to protect it any other way than giving as much tumescence as you can. So just think about a little extra tumescence beneath that vessel when you're treating with thermal. Tailor your thermal injury to the size of the veins to optimize closure. If you want to talk about that Shadykoff article, I think I've got it in the literature that you've got access to. It would be in your thermal folder, but small veins are not the same as big veins, and I think you have the opportunity to be more sophisticated with the tools that we use to make sure we're getting a good closure for these patients, and to recognize when you're not getting the response so that you can prepare for that. If you're using chemical, just make sure you have adequate concentration that's sufficient to do the job, whether it's Varithena, Sotradecol, Polydocanol. All of these chemicals have a role, and they can certainly manage a lot of anterior accessories depending upon their presentation. And when it comes to glue, I'd say keep some extra glue around when needed for short, large segments near a junction. I think if you've done this a long time, you know you can treat those with sclerosants, and you know you can get some good near-term responses. But some of these junctions are pretty tortuous, and they're very large. And if you're able to deliver a few drops of glue in there and hold that pressure, it's almost like shutting off the spigot. The key with this is it's not billable. But if you've got a challenge like that, it's something that you might want to at least consider. Pay attention to the scans. We're all looking at scans, in our offices and in other offices. And I think it never ceases to amaze me. It's thought that only 15% of patients have the anterior accessory, but I believe it's far bigger than that. And that pathology is quite common as your techs scan them. So just pay attention to that, because you're going to see it quite often. And that's it. Thank you.
Hey, Marlin.
Well, Marlin, I got to tell you, you proved the fact that you were one of the smartest people I know. So thank you very much for that. That was a fantastic presentation. There's a question from one of our fellows, or one of our past fellows, I'm sorry, I should say. Mohammed Hassan said that does the complication rate increase with multiple cycles of ablations when you're doing these thermal techniques where you're giving 3 or 4 cycles? Any thoughts on that at all?
A very important question, and thanks for sharing it, Mo. I've been doing this for many years. And when I say that, I've been using this approach for many years. And if I was seeing more complications, I would have backed off. So I've looked at this as a way to kind of make sure I'm delivering the results that the patient wants, and that is symptom improvement. And for us, making sure that vein is closed and pretty successfully closed. So I haven't seen an increase in any complications with these techniques by tailoring the amount of cycles or energy given with laser or radio frequency.
Yeah, I tend to agree with that as well. So Mohammed, just like Marlin said, you want to pay attention. There's 2 ways to look at that, right? You can either look at the last 5 seconds and make sure that you're at the appropriate wattage there. I typically use the first 5 seconds. For me, I want to see the wattage below 20 within the first 5 seconds. So by the time the time cycle hits 15, I like to see below 20. And for Marlin, it's at the last 5 seconds, he wants to be at 13 for the 7. I think it's for the 7 centimeter cycle. Catheter, right? Is that right, Marlin?
That's correct. It's less than 40.
It's either one. And then the other thing you want to do is you want to make sure you pay attention to the patient. Okay. You want to, if they have any pain at all, I stop the ablation and provide additional tumescent. But looking at the wattage, monitoring the patient, making sure they don't feel anything. Yeah. And with regards to the complications, if you're not going to injure the wall of the vein enough, you're not going to wind up treating the patient. So ultimately, you're not going to cause a complication if you haven't injured the 3 layers of the vessel wall, like what Marlin has indicated.
Hey, Marlin, thank you so much for great presentation and some thought-provoking stuff, because I've looked at this wattage stuff. I've heard a lot about the wattage, but I have an issue with it, and that is that the injury to the vein and what we're trying to achieve is by that temperature, right? We are thermally injuring the vein, and we're doing that by achieving 120 degrees Celsius. And the water to me is a form of power, right? It is power. And the way I look at it, I have 2 vehicles, one going uphill and one going in a flat line. They're both going 60 miles an hour. One has a higher RPM and the other one has a lower RPM, but they're both traveling at 60 miles an hour. Here, we're achieving 120 degrees, regardless of the power. And it's the 120 degrees that is doing the damage. So and I looked at this and I really didn't go far into China, but I still conceptually do not understand why is a wattage to me so critical when really it's the temperature that is doing the work.
That's a great question. That's a great question. I mean, every cycle should get to 120 degrees centigrade.
Correct.
It was felt that was a sign that those last 5 seconds, that was a sign that you had a full thickness injury. And so that's why I'm doing it. I mean, listen, nobody wants to have a catheter placed back in their legs if they can help it. And I just think I'm using it not as a sign of the power, because they all should be 20, but more as a sign of that we should have a full thickness injury.
I think, Eddie,
Okay.
the part of that is how long are you at 120 degrees, right? I mean, it gets to 120 degrees, but how long is the thermal injury applied to that wall?
And that's correct. And if you follow the catheter, that I make sure that is usually within 2 cycles tones, which is usually giving you 120 degrees for about 14 to 15 seconds. And that's pretty standard. If you look at it, you get that dual tone. And if you look over and over and over again, you're achieving that consistently around 15 to 14 seconds. And if you don't achieve it, the machine actually will signal that. So to me, it's 120, and I agree with Marlin. One of the things, for example, I know people love Mocha, but one of the things that I found with Mocha is it's more recanalization. I don't want to do this again. I want to do it once, and I want to do it right, and I want that patient to be happy. But I do multiple cycles when I feel that the vessel's large, and I want to make sure, or somebody who has done this before. I usually will change the modality, but if they've been somewhere else and we happen to be with RF, I will do multiple cycles. I have no problem, and I think that people tolerate it well. And to what you stated, I do not see any increased risk of complications. But I'm just trying to be more technical here. The wattage part, that's always sort of like, I've tried to understand that. I try to obviously, I know we all have different experiences, but that's it. I don't want to drag this, but I was just wondering.
Hey, Marlon, I got a quick question for you. One of the things you didn't mention phlebectomy on there. Do you typically do your ablations and then follow through with the phlebectomy? A lot of these patients will have significant varicosities that come across the typical anterior accessory GSV pattern. Do you do them in combination together, or do you do them separately? And I wonder if that has an effect on reopening the vein with regards to all of this energy talk.
Well, Ken, I'm ready to do my third phlebectomy in 10 months. People don't want me to cut on them here in Alabama because we've got widespread injection coverage, but we do start to sclerose those vessels typically by the next week. There's only a single, well, there may be 2 payers that we cannot begin that process for a period of 6 weeks after we do the ablation. So I think we're getting on them quickly, whether it's chemical ablation. Boy, when given the option, most patients don't want me to cut on them, even though I enjoy doing it. But I like to get on it as quickly as possible, as long as payers allow us. And if we have to do it without the payers, then so be it. But we tackle it as quick as we can. So
okay. Any other questions, guys? Well, thank you very much, Marlon. That was awesome talk. One of the best ones we've had. So thank you so much. I hope everybody has a great day.
Thank you, Marlon.
Thank you, guys. Appreciate the support. Have a great one.